Good evening, everyone. Good evening from wherever you are joining us. We welcome you this evening to our second week of our mental health conversations. My name is Brenda Lormel. I am the founder of this amazing organization, the Haitian American Medical Association, and it is truly a pleasure to be here for the second week. Last week, we talked all about trauma in the Haitian Creole language and in English. And tonight, we're moving on to depression. I am excited about what's going to happen tonight with these wonderful speakers that we have lined up. A little bit about who we are. So HAMA exists to improve the health literacy and health outcomes of our Haitian American communities. HAMA was founded, in 2017. And it's been quite an interesting journey since then. This project in particular launched in 2018, and every year we would go out into the communities, our Haitian communities in Massachusetts, and do what we're going to do now in the Haitian Creole language in person in our schools, community centers, local churches. And now we're here because we're living through a pandemic, but we won't stop trying to reach our Haitian community. And we are very grateful to continue in our mission in doing so. We also, this project also has been funded by the National Networks of Library of Medicine, a branch of the NIH that's been supporting this project since 2018. It's our third year, and we're grateful for their partnership. Myself, when I'm not on a Zoom call or emailing or talking to the team members, the 26 different team members of this organization, I can be found at Massachusetts General Hospital. I work there as an oncology nurse practitioner in the Cancer Center. I've been involved in cancer care since 2012, almost 10 years, which is kind of crazy, but I enjoy that work. Enough about me. I would love to introduce you to our moderator, Christina Michelle. Christina joined HAMA last year. She serves in the fundraising committee, and I've learned a new skill of hers, which is moderating, and she does an amazing job at it. So Christina, welcome, and welcome.
Thank you so much, Brenda, for that. I am humbled to be here this evening. Again, just sharing a space with all of these minds. Welcome everyone, both on Facebook and YouTube, to our second installment of the web series that we have. Last week, we had a great conversation on trauma, and this week, both today, tonight, and on Wednesday, I hope we have a great conversation, a very open-ended conversation on depression. Just a little bit about myself. I was born and raised right here in Boston, Massachusetts. I am of Haitian descent. Both of my parents were fortunate to come to the United States. I now work at Moderna Therapeutics in large-scale clinical manufacturing, where I formulate lipid nanoparticles as a drug delivery option for what is hopefully to be the coronavirus vaccine. This evening, we have 4 great panelists that, again, is going to be sharing a virtual space with us here. And I'm going to just give them the floor, and hopefully each and every one of them can, take some time to introduce themselves, tell us a little bit about themselves, what brings them here tonight, and hopefully what they're passionate about speaking this evening. First up, we have Dr. Diona and Josie Augustin. Hello, good evening. Oh, I believe you're on mute.
Oh,
yes,
okay.
I just
awesome. Good evening, everyone. My sister and I are so happy to be here tonight. We wanted to say thank you much to HAMA for inviting us to participate in this panel. As you already mentioned, Christina, my name is Dr. Diona Augustin. I am a psychologist, and I am one half of the Mental Health Sisters, which is an organization that my sister and I founded to provide effective, culturally competent services to people in our area.
And my name is Dr. Josie. I'm the other half of the Mental Health Sisters. I also work in private practice in Plantation, Florida, mostly providing neuropsychological testing services to help children get the accommodations they need in school.
Thank you both for that. Next up, we have Tamara Leroy London. Good evening.
Good evening. Hi, everybody. I'm so glad to be here. And so my name is Tamara Leroy London, also born and raised in Boston. And I am a clinical social worker, licensed independent clinical social worker. I currently work full-time in a local community health center, supporting patients in integrated work alongside their medical doctors. And I also have a small private practice where I'm seeing patients individually and hopefully adding groups and things like that down the line as well.
Thank you so much. And last but not least, we have Josephine St. Cyr Saye. Good evening.
Good evening, everyone. I'm so happy to be here. I am of Haitian descent. Both of my parents were born in Haiti, and I was born in Haiti and came here at the age of 10 and have been here ever since. I'm a licensed independent certified social worker. I'm also a board member of HAMA, and I am so proud to represent HAMA in this capacity. I also work for Mental Health Agency in Brockton, and I'm a part-time faculty at Bridgewater State University teaching social work.
Nice, awesome. Thank you so much, everyone, for introducing yourselves. And we are just going to get the ball rolling. So first up, this is going to be a two-part question that I have. So first off, what are some of the signs and symptoms of depression that you can list? And the second part of that question is, are there any signs and symptoms that you have personally picked up on, that you have seen, whether it be in your community, in your place of work, that may not be noticeable to like the greater system, clinical system?
I mean, I guess I'll start. So when it comes to what are the signs and symptoms of depression, I think that for a lot of people, when they hear the words depression, they think of sadness. But what they don't recognize is that there are so many other symptoms that tend to accompany the sadness, or what we would call dysphoric mood. So some of the more common symptoms are lack of energy, lack of interest in pleasurable activities, a change in appetite, either you're eating too much or you're not eating enough, insomnia, meaning you're not sleeping, hypersomnia, meaning you're sleeping too much, restlessness and agitation, difficulty concentrating, at times thoughts of death and dying or suicide, feelings of worthlessness and hopelessness. Those are some of the core symptoms of depression.
Yeah, and I would also like to add that in our community, especially, sometimes those symptoms won't necessarily manifest in the typical way as what was listed, but sometimes what you'll see is a lot of somatic symptoms. So constant headaches, or, you know, sometimes you may feel that you're always tired, or you might experience stomach aches, or it's almost like there's a lot of tension in the body because we don't necessarily recognize what's happening. So we experience it somatically.
I also would like to add that people tend to isolate themselves as they become more depressed. They shy away from their friends, from their family, and sometimes the family doesn't understand what is going on, especially within the Haitian culture. And once people bring it to parents' attention, it can be difficult for them to understand that you really need to have patience with your child and to have that child be more busy, get them involved in different activities. And as psychologists on the panel can attest that sometimes medication is recommended, and that can be a challenge.
Mm-hmm, mm-hmm. I have a follow-up question. So I feel like some of, I guess, the signs and symptomologies that were listed could be seen in, I guess you would say, an average person, someone who may not be suffering from depression. So with that, like, how would you diagnose depression? How do you know someone has it?
So one of the things that we normally want to look at is, has there been a marked change in their functioning? So let's say, for example, if a parent comes and says to me, I don't know what's wrong with my kid. They never want to be around friends. You know, they always stay in their room. I'm going to want to know, have they always been like that? Is this something that recently started? Is there a change in functioning? Or is your child naturally a loner who'd prefer to play video games for 8 hours and has no interest in friends? So even though these symptoms can be seen in other conditions, you want to look at, has there been a change in functioning where the person did not used to be sad all the time, did not used to have crying spells, did not used to have lack of energy, lack of interest, insomnia, and so on and so forth, and then all of a sudden those symptoms pop up. That's what will help you to determine whether or not that person is having a depressive episode.
Okay.
Yeah, and you also want to keep in mind, has there been a recent stressor? Because if there is, then you may also qualify for, alternatively qualify for an adjustment disorder. And then let's say, despite the adjustment phase, let's say you've gotten past that phase and you're still presenting with those symptoms, or the symptoms you're experiencing are severe enough to meet criteria for depression, then you would assign depression. Otherwise, you would kind of monitor that adjustment disorder period to see if those symptoms will fall off after that phase has been done.
And how does depression exude itself amongst different age groups? So kids versus, someone in their 30s, 40s. Question for everyone.
I'm sorry. Children can be agitated. They can be angry. I do a lot of work with children, and of course we use play therapy, sometimes just playing Uno with them, and then they just lash out. They will cheat to make sure that they are winning in a game. It's interesting to see the dynamic with kids playing a game. They'll go, I had one young boy who'd go to any means to win. And the one time I won, I was kind of nervous as to how he was going to react, but he took it pretty well. So in children, you will see that. And I think in adults too, you see the agitation, probably anger, not wanting to engage with people and when they were engaging before. And it's what she said about one of the sisters, sorry, which sister? Josie. What you said about adjustment disorder is really true to look at, because sometimes it could be a situation, it could be some trauma that's coming up that is making that person go to that period at that time. I'm also very careful in terms of giving diagnosis, because a diagnosis really stick with your name. So sometimes if you're not certain, it's better to give an adjustment disorder with the depression, anxiety, whatever else comes with it, psychotic features and things of that nature. Yeah, that's what I wanted to say.
And could you, because I personally I don't have any knowledge about, I guess, adjustment disorders. Could you touch a little bit more upon that?
Adjustment disorders are relate to situations that someone could be going through, and they don't meet the full criteria under DSM-5 for, let's say, depression, a major depression, depressive episode, or anxiety, or generalized anxiety disorder. So I would give them an adjustment disorder, which would imply that they are going through something in their life at this period of time that they're having a tough time with. And in due time, sometimes an adjustment disorder can become a full and general anxiety or major depression, because DSM-5 kind of gives you timelines that people have to be certain 2 to 3 weeks with the symptoms to meet that criteria. And there's multiple criterias.
Okay, got you. And are there different forms of depression? Do they like highlight themselves in like various formats?
Well, you want for me or anybody else?
Anyone. Very open-ended.
Yeah, I can jump in. Yeah, there are a lot of different forms of depression. Like you talked about the adjustment disorder. We can see depression come with adjustment disorder. We can see depression with major depressive disorders, or even persistent depressive disorder, which is kind of more chronic low mood. And even other disorders can have depression attached to it. For example, bipolar disorder. We can also see the sides of somebody going through depressive episodes and manic episodes. And, various other diagnoses as well. Depression can kind of come with a lot of them as a component. So there's a lot of different forms of depression. And so that's why when we're diagnosing, we want to be really careful to make sure we are really understanding our patient and not just slapping a label on them. Especially, within the Haitian community, there's a lot of stigma around, somebody having a mental health diagnosis. So it is something that, when I'm working with my patients, it's something that I'm very careful about, and making sure that I'm getting, the full information to make a solid diagnosis. And if I'm still assessing, like I think one of the sisters said, we might, or maybe it was Josephine, we might go with adjustment disorder as we're still sorting it out to make sure that we are getting the full picture.
Follow-up question. It seems that depression is observed, or like the characteristics that can lead to a diagnosis of depression is observed throughout time. Is there like an average timeline that, clinicians tend to diagnose depression? Like how long on average does it take to diagnose someone with depression?
I think a lot of times when we are doing our assessments, we are asking a lot of questions on the history of the symptoms. So we may find that the patient in front of us may have been experiencing depressive symptoms since childhood, or we're finding that with COVID, they started experiencing these depressive symptoms. And those may lead to two different diagnoses. I think the history part is very important. And, when to do a thorough assessment, we're often meeting with that patient for an hour to start. And, that may go on for several other sessions to really get all the information we need to diagnose.
Thank you so much. I want to delve.
Can I just add one
Oh,
more
of course.
thing?
I'm sorry.
In terms of the depression, at my agency, they use kind of like a scale that overall rates everything. It looks at, PTSD, post-traumatic stress disorder, depression, anxiety. And then for children, we have another scale that has kind of like, I think, 104 questions. for the parents to complete, and they can make suggestions that they don't replace our assessment, but they can highlight kind of the features of what somebody is going through.
Great.
One more thing I was going to add is that for some diagnoses, the timeline may be different in terms of diagnosing children versus adults. So for example, that persistent depression that was referenced earlier, that's a chronic low-lying one. For adults, you would typically have to have at least 2 years in terms of what they report in terms of feeling depressed. But for children, it only has to be 1 year. So in that sense, the timeline can vary based on the population that you're seeing.
And do you know why that is? I'm just, for my own personal knowledge, do you know why the timelines differ between those various age groups?
Based on things that they've said in terms of the researcher in class, sometimes it's just based on a child's presentation versus an adult's presentation. I'm not going to necessarily get into the stats because that's boring, but usually when they're making diagnoses or assessments, or they're developing those books, they base it on a sample, and they kind of look at, in terms of the population, how long does it take for us to see this? And then it's kind of like criteria are developed based on the sample that they obtained from the population. So for kids, it's almost like they don't typically experience those symptoms in that long of a time frame. So once you see it exceeds 1 year, that's concerning, as opposed to an adult might react to certain things differently, because adults have different levels of emotional regulation than children do.
Okay. And do you mind quickly explaining what DSM-5 is for our viewers? It was mentioned previously. In the most basic way, if you had to.
The DSM is the Diagnostic and Statistical Manual of the American Psychological Association, and it is basically a psychologist, therapist, social worker Bible. That is what we use to diagnose people, to figure out differential diagnosis, if we're in between diagnoses, to look at the etiology of diseases, and then to also look at conditions that are specific to certain cultures.
Okay. And just to rally back to the definition of depression, how would your personal perspective on the definition of depression, how has that changed throughout time? So you being, 14, 15 years old, not having any clinical experience, how would you have defined depression back then, and how would you define it now? How did that change?
I think for me, when I was younger, I thought depression was just, you're sad and maybe you're moping around, or, just not really thinking there was much to it, but you're sad, or maybe you're crying. And at this point in my career, especially with working within a health center, I see so much of the somatic responses, those physical responses that come with depression. And so I know there's so much more to depression, whether it's aches in your body, or, that lack of motivation, loss of interest in doing your usual activities. So I have kind of that clinical understanding, and also like that cultural understanding that's really, really important, of just kind of, because, a Haitian patient may not come and tell you I'm depressed. They're first talking to their doctor about the pains they're having in their body. And then I may kind of come in and check in with that patient, and then we're able to identify, some of these responses as forms of depression, as manifestations of depression. So depression, has these physical responses and these emotional responses that are all kind of really cumulative to the diagnosis.
One of the things that I wanted to just add to what Tamara said is, when it comes to the Haitian population, sometimes when they come in to see you, they don't mention the word depression at all because their understanding of what they're going through is just that something's off, but they have no idea what it is. And I can remember I specifically had a client who came in who was like, I used to love cooking for my family. I used to love spending time with my family. You know, she felt like she was a horrible mom, horrible wife because she wasn't able to do all of the things that she used to do. And as she talked about all of the struggles she was having, and I said to her, it kind of sounds like you're depressed. And she kind of had a, what? Depressed? Me?
It can't happen. It can't happen.
Exactly. Like it never even occurred to her. And then as I start to list off what she is telling me and what specific symptoms they fell under, she was like, oh my gosh, that's what I've been feeling. But she did not have the verbiage for it. So in that sense, similarly to Tamara, when I was younger, depression meant sad. But as I've gotten older, I noticed that it can manifest in many other ways other than just a sad mood.
And sorry.
No, go ahead.
I was going to say thank you for that anecdote. I was just going to ask, like, historically, do you know where that comes from? Why are certain social groups, like prone to having like a certain cliche about what depression is and like why it exists, or even if it exists?
Yeah, I think that goes a lot with how mental health is conceptualized in our society as well as back in Haiti. One of the things that I found actually during my dissertation research is that mental health institutions were not well developed, at least at the time of the research in Haiti. So if you heard mental health or seeing a psychologist or psychiatrist, it was people who were locked up. Like these are the people who are in asylums, who are pretty much institutionalized because the society doesn't know what to do with them. So I think they bring over that conceptualization over here, and it's still seen under that negative light where it's like, oh, if you are at the point where you have to see a psychologist or a psychiatrist, then you're crazy. Like that's how they view it a lot of the time, and it's very stigmatized. And the one thing I would add is different. I did also perceive the sadness, just like the two of them stated. But one thing that I learned as I move forward clinically is that you can be functionally depressed. And I think a lot of our people do that. You still go to work, you still go to school, you still do your day-to-day, but your functioning is not the same. It's not at the same level at what you're used to. So you don't recognize you're depressed because you're still able to do what you normally do, but you don't notice that I'm not doing it with the same spirit that I used to do it, if that makes sense.
And what are, in your opinions, are some of the factors, whether environmental, genetic, that could lead to, if that's even possible, to depression? Social factors.
I think sometimes the environment that somebody lives in adds a lot to how depressed they are. And with what's going on right now in America, with the aggression toward Black people, that can make people very depressed. In my, not my own, I don't have a private practice. I intend to have one, but with the clientele that I'm working with during the protest, you would be amazed how it impacts people. And when they come in for a session, I may have my plan that I have to do an intake and I have to update paperwork with them. It goes out the window. What they wanted to talk about is what is going on now, the protests, how they're being impacted, how people are calling them names, and how depressed that they feel about all that. And is change going to really happen in the society? And having been around for a little bit longer than you guys, I'm hopeful about that change will happen. And I encourage them that change has happened, but it needs to continue to happen. And all communities, and the Haitian as well as other cultures.
And have you seen ooh, and have you seen a rise in, depression or depressive states within certain groups, whether that be, African American, people that live in urban areas versus, non-urban areas? Have you seen, an increase, or have you like gotten more clientele per se? Like, have you noticed any of those are those pinpoints?
I have seen it across the board, not just only with Haitian, with other clients. Because I had one of my clients, we do EAP, that's Employees Assistant Program, at times. And this one woman who is Caucasian, she asked me, what can I do? And she says, don't take offense, Josephine, but how do I know I'm not racist? And that just kind of put me in an awkward position. And I referred her to a few resources in terms of getting some help around that, because that was our last session of the EAP. And she hasn't returned back, so I'm hoping she's coping with it. But I think people were really depressed, and were really indecisive as to whether they should take part in the protests, the demonstrations going on, and on top of it, COVID.
Yeah, I was going to add to what Josephine said. I have seen a rise in not necessarily just depression, but sometimes it's depressive symptoms where the person doesn't meet full criteria for a major depressive disorder. But I have had clients who had been terminated, discharged from therapy, who after the pandemic started, called me up and said, I'd like to come in for a few more sessions because I'm having a hard time dealing with my job or being laid off or my family. Then on the flip side, I have had some of my clients who are of African American descent or who are people of color who have actually evidenced depressive symptoms related to the racial climate, police brutality, the things that they're seeing on the news. So that's something that I've also had to work with them on, because like Josephine said, the way that things are, a lot of people are just tired. They don't know what to do, but they know that they are bothered by what they're seeing and what they're witnessing. And a lot of my clients have expressed concerns about their kids and the fact that their kids are seeing this, and now the kids are expressing anxiety. So it's something that it's building, and there are other issues that are also coming into play.
Wow.
I would also add, in our community, sometimes what you see is a culture of stressors, in the sense that some people are still adjusting to living here, and some people still do not have papers, or there are other concerns going on. And it's almost like this adds another layer of stress, in the sense that people are concerned. And it's not just with the police brutality and the opposition going on and the institutionalized racism, but there are real concerns of what could happen to us here, because they were literally leaving to escape a particular climate, only to encounter another climate in this society, to the point where there are studies that have shown that even people who are citizens here, so they've gone through the process, become US citizens, they still fear deportation. Which to us sounds like, what? But because of what they're seeing, they're having a hard time living, with kepoze, I would say. Like, they don't feel relaxed. They don't feel, that they're at home here either.
And how do you all think that this will look down the line 10, 20 years from now? Because I feel like a lot of things that were once pushed under the rug are now being shown in the limelight. So how does that look like? How does depression look like, 10, 20 years from now, with everything going on?
I mean, I think that when it comes to the depressive symptoms, we're always going to have that show up in different populations, different settings. What I am afraid is going to happen right now is due to the racial climate, we might see an uptick in terms of African Americans or people of color who are presenting with more depressive symptoms. My
Okay.
concern is, will they actually seek help? So, for example, in the Haitian
Mhm.
community, there is a stigma associated with mental health. So, when people hear the words, depression, depression, anxiety, inquiétude, in their head, mental health equals fou or crazy. That's it. There is no in between. It's black or white. So what I'm
Mhm.
worried will happen is that people of color will have depressive symptoms, maybe even more than usual, but will they necessarily have access to the resources they need, or will they access the resources if they have them? That's what my concern is. And then what normally happens with depression, earlier you guys asked a question about factors that lead to depression. There is
Mhm.
a large genetic component in the sense that depression tends to run in families. So if you are being raised in a climate where you are witnessing police brutality, you're hearing about people,
Mhm.
getting shot for no reason, if that leads you to experience depression, let's say, for example, if you're a woman, if a woman is pregnant and experiences depression, her child is likely to show some kind of symptomatology as they age. So it
Wow.
becomes this vicious cycle that we really have to kind of catch as early as possible to minimize the likelihood that people will experience it later.
Mhm. 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 Thank you so much. Does anyone have anything else to add?
Yeah, I think you make a great point. And I also wonder, as things progress, is is mental health ever gonna be more normalized where people are going to feel more comfortable 10 years from now reaching out for help? Are Haitian patients going to feel more comfortable reaching out for help? And I think too, on the flip side of our are the mental health practitioners are we becoming more diverse where more Haitian or African American clinicians are coming into the field where we can draw in more Haitian patients or more African American patients so that they will feel more
Mhm.
comfortable with
Mhm.
seeking
Mhm.
care. So that's a that's a thought that I wanted to bring up.
Do
Yeah.
you all think that there are certain groups amongst the Haitian community that is more prone to experiencing depression? And if so, why?
I think one group that I have worked with, I think the elderly
Okay.
population, um, because they've done their work and raising their children, and some of them may tend to feel that sense of isolation because children move to get better job opportunities, um, and things of that nature. And also in the Haitian culture, we are raised to be strong. You can do everything, and you don't want to show any signs of weakness. So all that, and when you're getting older and you experiencing your own losses, um, that will cause some depression. And people, some of them, as someone had said, don't know. People will say, "Comme crasé," my body's beaten. That's the best translation I can come up with. And what does that to me? That says it's kind of indicative of depressive symptoms, but people may not say that. I kind of grew up back to a question we talked about is that um, what was depression? I never understood depression, what it means, depression, um, until I really became a social worker to say, oh, that's what they were talking about. So I think the elderly population has that because if you're not working anymore, and sometimes, and I'm not saying this broadly for everybody, as Haitian get older, they don't get involved. they don't participate in things like volunteering and doing things like that. So I think they are more prone to depression. That's just my opinion and what I've seen in my lifetime.
Mm-hmm. And do you feel that, partaking in activities like volunteering and philanthropy aids in, I guess, someone who is depressed?
I would say in life we have different stages in life, and I feel as you get older, it doesn't mean that things are over. And I think there's kind of that mental state, and that things are over for you. Just sit and wait. But if you stay busy, you get involved in your church activities. You can do. Recently, in my church that I go to, I talked about, what about doing mentoring, something like that? That somebody older take on someone younger to just kind of give them support. Or if somebody's in college, send them a card and just send them a little basket of fruit and different things before COVID. And that really encouraged them, and that keeps you busy. So I do think that it does help a lot. It uplifts your spirit.
Mm-hmm.
I would echo Josephine's point. I think helping people helps you. And I also have noticed in my clients who present with depressive symptoms, I can always tell the ones who are going to sink further into depression versus the ones who will get better. Because a lot of times the ones who will get better, even though they're feeling crappy and they're feeling depressed and they don't want to get out of bed, they force themselves to do things. So, for example, I had a client of Haitian descent who was an elderly woman who was feeling depressed, and she told me, I'm going to go volunteer at my church. Within a matter of 1 week, the next time I saw her, it was a completely different experience. Wow. And it was because she stopped staying at home, where you're going to be thinking constantly about the fact that you're older, you don't see your family as much, you're not as independent as you used to be. It forced her into another role where she's helping, where she's doing, where she doesn't have to feel like as if she can't contribute anything. And it led to a major change in her mood.
I too echo what the both of them are saying in terms of the population, but I'm going to add another layer to it. But it's almost like it's more likely that you'll find this in the elderly population. It's your ability to adapt. Your ability to adapt will significantly impact your likelihood of experiencing depression. And sometimes it's harder for older people to adapt because they've grown accustomed to the way that things were back home. If you're focused solely on the way things were back home, you're going to have a very difficult time adjusting to things here because so many things are so drastically different. And I think it's getting to that point of recognizing it's just different. Doesn't necessarily mean it's any better or that it's any worse. But what I've noticed is kind of the dichotomous thinking that we've been hearing throughout this segment, where a lot of times it's either or, it can't be in between. So I'll see some people who are more of the elderly Haitian American population, and they're critical of everything going on here because it's not the way that it was back home. Now, I'm not saying everything here is great, but if that's the perspective that you're carrying all the time, you're going to feel depressed. It's just more likely that you're going to experience that, as opposed to if you take a more adaptive approach, then you're likely to surmount or get over that a lot more quickly.
So like the constant comparison of what was versus what it is now. Okay, right. Gotcha. I did want to backtrack. I know we did mention, church. I know, religion and spirituality are common things that are usually brought up, when depression is spoken about. How do you believe religion and spirituality affects the management of depression?
I mean, I think it can go in multiple directions. When it
I
comes to religion and spirituality, it can help if you engage in what we call positive religious coping. So, for example, believing that even though I am depressed, God has a plan, God is going to help me get through this. I'm not abandoned, I'm not alone. I have God, I have my church community. Thinking like that can actually help you to manage your depression. If, on the other hand, you engage in negative religious coping strategies, so for example, believing that this is an attack of the devil and this is why you're feeling this way, feeling like you've been abandoned by God, thinking that if prayer and having faith doesn't work, you're always going to be depressed. You don't feel like you can go see a therapist because Jesus is above all therapists and Jesus is the ultimate doctor. So you don't need to speak to someone. In that sense, it can then become something that handicaps you and keeps you from getting the help that you need.
And I'll briefly add, I actually was doing a study on this where I would ask people, I actually did it qualitatively to get their comments and their stories regarding how religiosity and spirituality affected their coping. And some of them took it to mean this is the load God gave me, so I just have to deal with it. It's like I've resigned myself. And it's like, this is the cup that I was dealt, so I have to drink it. So I think a lot of times too, that affects the way that they cope with it. And other times they add on a spiritual nature to it in terms of the cause. So if it was caused by a evil spirit or a mauvais l'esprit, we have to pray it away. We don't go see a therapist for that because, the mauvais l'esprit a rentré sous timuna or sumuna, and that's why they feel depressed. Basically saying the evil spirit is in this person. That's why they're unable to cope with this depression or they feel this way. So the way that we think about the disorder impacts how we treat the disorder. If you perceive a spiritual cause, then you seek a spiritual solution.
I concur absolutely with what you're saying in terms of that. There's another Haitian saying, si Dieu veut, and also, I put it down in my notes. Si Dieu veut means if God implies it, that it's going to happen. Bon Dieu bon, God is good. All these different kinds of delays people response. I'm not saying at all that there's positivity in terms of believing, and research shows that does help people. However, on the other hand, and people seek advice of their minister, the pastor, and do they have enough training? Do they know when it's time to say, you may really need to see somebody else? So that's one of my concerns. And the environment of some churches can give you great support. And however, there are some churches too, there's so much gossiping and things going on that they discourage you from going there and being there. So it's both ways. If the training is right with the pastors, with the ministry, that can really help somebody to get them in the right place. And then thus that could remove some of the stigma around it. We talked about people being fou and things like that. Any behavior that's different was perceived as crazy. I remember that growing up, and people wouldn't try to understand it when maybe a medication could have helped that person and they could really function. But then you get into the whole debate, medication, compliance, staying on the medication, you get better and you just go back to not taking it, etc. We could talk another hour about that.
I agree with everything that's been said. There's been this, saying you can have Jesus and a therapist too. These things don't have to be separate. They can be together and they can be amazing together. So, I love that saying. And I think it's that's such a great thing for our community as well, that these things do not have to be separate. These things can be together and support you in your mental health and your well-being. So I absolutely support my patients in pulling on their faith. Of course, that is something positive for them, pulling on their faith, for them to have that hope and that motivation to manage their depression. These things don't have to be separate. They work well together.
Mm-hmm. That was actually going to be my next question, because it seems like there are two extremes fighting against one another. How do they, coincide in the same space?
I think part of the assessment, when somebody comes in for the initial assessment, you need to draw out, do they have a faith system?
Okay.
What's their support looks like? Whether family some churches can have a nice support around someone, and recognizing if someone goes to a loss, what's a reasonable time to grieve that loss? And if somebody's lingering too long, then maybe that might be they may need some grief counseling to help them with that. And it depends on the loss. So I think that's really important. And if people have faith as a therapist, I encourage them to use that as long as it's positive. But sometimes I run into, as my work prior to doing just solely therapy, I used to work for DCF. It's a child protective agency in Massachusetts. And the symptoms would be clear to the parents, and you would be trying to convince them. And until a child had a breakdown at school, they end up being hospitalized. Still, the parents wouldn't believe it. So we could use their pastor to help them to understand it. Somebody really that good. So you can bridge that to make that work.
Nice. How do you have a conversation about, depression or depressive states within, a community such as the church, even your local community, your immediate family? How do you even start that conversation?
Well, at church, you could use the church as a way to bring in trainings so that people have a platform to hear about mental health. That it's part of, the more we normalize it, as Tamara said, the more people will be more accepting of it, and we could take away the shame of it, that if your child really needs help, it's there, that it's seen that this could happen to almost everybody. But it's how you approach it and it's how you treat it. If you ignore it, it's not going to go away. And it's not going to just get better by itself. And sometimes I think when parents see that, and you break down, some of my work with them as a social worker for the state was really simplifying it to just say, look at what he's doing. He's really talking back to you, and in the Haitian community, that's not acceptable. But what's behind that? Somebody alluded to that before. What was their behavior before? You had a child that was acting perfectly, and then something drastically changed. So it's going back to look at what happened. What was the factors? Did they pick up on that? And are parents present? If they're working too much, they're not home. Sometimes they have to make some shifts because it could be attention-seeking, behaviors as well that's going on.
One of the things I wanted to add, I definitely agree with Tamara about normalizing the conversation. And then also the point that Josephine made about contacting pastors. I remember my sister did her dissertation on barriers to help seeking among Haitians. And one of the things we have to keep in mind about the Haitian community, an appeal to authority, especially spiritual authority, can go a long way. So if it's their pastor, if it's their priest, if you can get those people on board with treatment, a lot of times, as Josephine mentioned, it bridges the gap and makes it more easier for them to actually accept therapy or medication or whatever it is. So don't just assume that the church or even the Haitian church will be against it. Actually offer them the opportunity to sit and talk with the pastor or the committee or the board, about mental health and mental health services that you offer, and then offering to do presentations, maybe at a Friday night or a Sunday night service, telling them ahead of time, send in your questions and we'll answer them. That will go a long way, because when they see my spiritual leader actually does believe that this can be beneficial for me, it can go a long way towards kind of attenuating some of the stigma so that they can get the help that they need for themselves or their family.
Yes. And the other thing that I would add to that is that one thing that they've taught us is that you don't get people to come to your side by dismantling everything that they know. Mm-hmm. We don't necessarily have to agree on the cause in order to work towards the solution. Mm-hmm. And I say that because I remember there was this story that about this woman who she had a child, but she basically believed that the child could not learn at school because they did some voodoo and they put the child's brain in a bottle. And because of that, it was like, this is the only way my child will learn. And while the initial parent focus was just praying and, fasting and trying to get it out, the therapist comes and tells you, what if I told you I knew how to get your child's brain out of the bottle? And by that, she's incorporating mental health solutions. She's incorporating accommodations, assessment services. So you still get the treatment, even if we're not necessarily on the same page about the cause. Mm-hmm. And I think that when you don't completely invalidate their belief system, it makes them more open to receiving your help. So I think that in terms of even when you do psychoeducational presentations or whatever it may be in the church or wherever, you can always keep that in mind so that you don't completely dismantle their system, but at the same time, you're offering solutions for the problems.
Mm-hmm. Wow. Thank you for that. Is there anyone specifically who, and this is so that the audience can know, is there anyone specifically who is a trained professional that deals with, diagnosing depression? Is there anyone that is trained to aid someone in their process of healing? And who is that? Oh, I think you're on mute.
Yeah, no, I was asking, do you mean like amongst us or do you mean in general?
In general.
Oh, okay. Because I was like, I think all of us, but okay. Yeah. But yes, I would say definitely you could a therapist, a counselor. The only thing I would say is try to ensure that the person that you go to is credentialed or is working under someone who is credentialed, because that's the only way you can truly kind of validate that these people know exactly what they're talking about and they have some type of knowledge in the field. Because what we have is people who just do things casually. And when you do things casually, you could end up misdiagnosing someone or not considering all of the factors that could be contributing to their presentation. And then you fall into that whole over-pathologizing, type of thing where you're misdiagnosing or you're assigning a lot of issues, but only because you're not aware of all the sociological factors, psychological factors that are coming into play when you see this client. So that's the main thing that I would say.
And I'll also add, if you're ever feeling like you're in a mental health crisis, if you're feeling like you're having thoughts about suicide, which we know can sometimes come with depression, these are things that you can get help with right away. You don't have to sit in that by yourself. Finding ways to go directly to a local emergency room, or even calling 911 or a mobile crisis unit in your area. These are ways that you can get immediate help so that you're not sitting in these really challenging thoughts and emotions, and you can get support for yourself right away.
I have a question.
That's a great point that you made, Tamara.
Any other thoughts? No, I have a question. So I feel like in this time, people are pushing an agenda of, supporting Black businesses, and with that, supporting Black clinicians. Do you think there is a benefit of, you know, I guess like Black clientele going to Black clinicians for help versus, someone who's white, someone who is Asian, Hispanic, Latino? And what are those benefits of speaking to someone that looks like you for assistance?
I definitely think there's a benefit. I would even say that in some cases, it can make the therapeutic relationship have a firm foundation, as opposed to if you're working with a clinician who is not of the same racial, ethnic, or cultural background, you have to do more work. But I can remember specific times where I've had clients come in who either were people of color or who were of Haitian descent. Just being able to speak the language just connected us in a way they would not have had if it was with, let's say, for example, a white therapist. So that isn't to say that you can't be helped by a white therapist, but there is something to be said about having someone who is the same race as you, who knows what it's like to be a victim of racism. You don't have to explain it to them. They get it. They understand. Just like you have concerns about police brutality and the racial climate, they have those concerns too. So they can empathize and relate in a way that a clinician of who is white may not necessarily be able to relate. And then when you have that shared racial, cultural, or religious background, it can also help to connect you because you guys have this shared foundation or base to pull from.
I absolutely agree with what you said. And some clients will go as far as asking for a person of the same culture and background within an agency so that they can be sure that they're going to have that experience, that they're going to feel that empathy that that person may have for them. And also as you work with somebody initially, it takes time to build that rapport with the person. The clicking may happen. And we are trained, all of us, to be accepting of everyone. But that person may feel a special connection because when you say, what's your culture? And you say, oh, I'm Haitian too. They're like, whoa, okay, there's a party going on. That we're the same culture. But on the other hand, what I've gotten when I was a social worker for DCF, I've gotten some Haitian that says, don't send a Haitian to my home because you're going to spread my stuff in the street. You're going to share with the community. When you don't even live in the community. You come and work in the community, but you may not live in the community. So there's that misconception sometimes. But once you sit down with them, and I had this one quick story I'll tell. I had this one woman, I went and I was a social worker. Her case had been supported. And we were talking. She's like, I'm going to throw a bucket of pee on you. And then I just kept on talking to her. Next thing we were in her living room, sitting down talking. She was offering me, do you want some drink? Do you want some coffee? Because we just kept on talking. And I have to say that was one of my better experiences, and really, breaking things down to her. We're not here to take your kids, but we have services. We can get you daycare. We can help you with housing. We can help you get your kid evaluated to see what's going on, why they're acting up so much. So it's like bridge work and slowly doing that work with people and having the patience and compassion and understanding.
Mm-hmm. Excellent. How does anyone seek out therapy? Are there specific resources that someone can find in their local communities or online to aid them in that process? And then as a follow-up question too, and I would love to know, what is the appropriate way to ask for a therapist of color? If you prefer someone of color, how do you go about that?
So thankfully, there are multiple ways to find a therapist. Of course, the most common organization is psychologytoday.com. You can actually filter it out by different, features, gender, race, religion, and so on and so forth. There's actually sites specifically tailored to people of color. So for example, there's therapyforblackgirls.com, where you can find a clinician of color. And then there's also therapyforblackmen.org, which is tailored to men. And then with regards to your question about how do you ask, honestly, you have a right to ask for the therapist that you want. Don't allow anyone to make you feel weird just because you would like someone who is female or who is Black or who is of Haitian descent. One of the things that helps therapy to work is good therapist-client fit. So if you feel like you will be more comfortable talking to someone who looks like you or who shares your religion or cultural background, it is perfectly okay. Let's say, for example, your doctor gives you a referral to say, I appreciate the referral, but I would actually prefer if I had someone who was Black or who was Christian or whatever it is. And then they can point you to resources, or you can go to the websites that I mentioned before to find a clinician of color.
Another great website that I'll add is InnoSite, INNO-site.com. It's a directory for all clinicians of color, therapists of color. So that's another area to look. And I agree with Diana, where you have the right to ask for what you want for your care. When I opened my private practice, I got so many requests from people who were looking for a Haitian therapist because it's invaluable to the therapeutic alliance and the therapeutic experience. So you have a right to ask and you have a right to look for it. There's not many of us, unfortunately. And I think that's where the challenge comes, because I've gotten flooded with referrals, and unfortunately I'm one person and I can't take them all, and that also doesn't feel good. But there's such a need in our community. People are reaching out. Keep reaching out, keep looking. Even if somebody doesn't have an opening, keep looking. Another great way to look is through your primary care. A lot of primary care doctors have therapists kind of attached with them. Like I mentioned, I do some integrated work, meaning a patient will go to their doctor's appointment. They may identify some mental health concerns with their doctor. The doctor is pulling me into that visit or sending me a referral to then follow up on the mental health concerns. So a primary care can be a really great way to find resources to clinicians, to therapists.
Awesome. Thank you for that. Any other last comments? Nope. All right. I actually have one more question for you all. This has been great. I know we briefly touched upon it, oh my God, moments ago, but what factors do you believe help protect against depression? I know for me personally, if I'm ever feeling a little bit down, I like to go to the gym. There are certain genres of music that I like to listen to, but are there any specific factors that you all have seen to help, that is known to help protect against depression? Sorry.
I'm actually glad you brought that up, because I think a lot of times we look at risk factors, but we don't look at protective factors. And I think it's very important to not only know what doesn't work, but to know what does work. And one of the things that I've seen a lot that comes up for our group in the literature is actually the religious aspect of it. But like Josephine said before, sometimes there are negative effects of faith-based coping. Let's say you go to church and people are talking about your problems. So you have to keep those things in mind. But in general, that tends to be a protective factor for most people, and not just Haitians, but people in general, to actually believe that there is a greater purpose, there is a greater cause, and everything is going to mean something and it's going to work out for your good. So I think that's something that we have to keep in mind as a very strong protective factor for our group. And I think just having certain coping skills at your disposal also decreases your risk, because if you think about it, coming from a system that doesn't know much about mental health, what we lack are coping skills. We don't even know what to do because we don't even know we have the problem to begin with. However, in the groups where they've actually been equipped with coping skills and they have things that they can pull from to know, if I'm dealing with this, I can do that. Or if I'm facing this, I can respond with that. That usually helps them to not experience depressive symptoms so severely, because what depression is, in terms of, if you're thinking the archaic definition of the word, is learned helplessness. So when you have tools in your kit that help you to feel empowered, it decreases the likelihood of you experiencing depression or long-term depression, because you know that you can cope with what's happening.
Another protective factor I'd add is social support. One of the things that I think we have to keep in mind, one of the main symptoms of depression is that emotional withdrawal, social isolation. Speaking from my own experiences in Haitian communities, Haitian churches, when people are feeling depressed, they do tend to kind of back away from participating in social activities or participating in things with their families. And if they don't have that social support, they start to feel like, man, nobody cares about me. Everyone has abandoned me. So having a source of social support, knowing that your family is there for you, not necessarily saying that you as the family member are trying to fix the depressed person, but letting them know, I'm here for you. You need to talk. You need someone to just listen. You have my number. You can come to the house, do whatever you have to do. Social support goes a long way. And not having social support is always an issue in not just depression, but in a lot of other psychological conditions.
Mm-hmm.
I also would like to add, for parents of younger children, really strong family functioning really help children. Unity in the family, that the family get along. They're able to talk about things when things come up. Those are key things for young children, is having some self-esteem, praising them a lot, because growing up as a Haitian woman, I don't remember a lot being said, good job, and things like that. The expectation is that you're going to do it, and you're going to do it right. And then you just don't know, if you don't do something right, what's going to happen. But that kind of instilling those kind of things in our children are really beneficial to them. And if they can't do something too, that it's all right. You may not be good at basketball, but you may be good at volleyball. You may be good at writing. Identifying what your child is good at and building on that. All those things are protective factors and dealing with depression.
Great. This has been, oh my God, amazing. I know I've learned a lot. I'm going to open the floor, actually. That's all the questions I have for tonight. But I'm going to open the floor for 5 minutes to give you all a chance to give any last minute remarks that you may have, any feedback, any other last minute thoughts that you would like to share for the audience.
So I would just like to add that it starts with us. It starts with the people who are not only guiding this discussion, but people who are listening to this series. It's up to us to kind of get the message out there and help normalize this for our group, because what is that saying? There's actually a Haitian proverb that talks about maladie cachée pas joindre remède or something like that. It's almost like if you're sitting here and you're trying to hide whatever's going on, then you're not going to get the support and the help that you need. So I think it's up to us to kind of band together however we can across domains. So the mental health professionals, with the, you know, the church leaders, with the people who are in the head of, like, you know, medical organizations in our community. And it's kind of like all of us doing this joint effort to help reduce stigma in our community and get people the assistance that they need. So I think if we all work together to change the narrative, then I have hope that things will be better for future generations.
I completely second my sister. I think she said it all. I think one of the things that sometimes we do is when we see a problem like this, we kind of feel like it'll never be fixed just because it's existed for so long. So I guess my last remark would just be to remember that it starts with one. So to all of our viewers, be the one who starts the conversation, the one who, you know, does the presentation, the one who reaches out a lending hand or an ear. Be the one, and you can be the catalyst for so much change in your family, church community, environment, and so on and so forth.
I absolutely agree with you guys. You took away all my words. and well said. I think too, just one thing, people should have an open mind to the work. And one thing I like to add, if a therapist doesn't work for you, find another one. Before you find the one that really you can have that conversation, you could feel free to open up. And to also know that there's confidentiality. I don't think we touch on that because people are so fearful that their story, what they're dealing with, is going to get out. And there's a fear of that, and that it's contained and it's not going anywhere. And we're there to help you. And also there's a willingness to change. If somebody comes into therapy, have the open mind that do some of the exercises your therapist refers you to. Get up and walk and things like that, and be very gentle. I feel as a therapist, I try to be very gentle with people. To get them to step one sometimes takes 2 or 3 months. And it's once they open and they start seeing the change, they're like, wow, this really works. That's what just the openness is what I would like to give to people that are listening to this. Be open to it.
I second everything that was already said. And yeah, definitely if you're feeling depression, if you're feeling something is off and you don't know what it is, check in with somebody. And, you know, like Josephine said, you know, if it's not a good fit, you can always try somebody else. And you can also give your therapist feedback. I try to regularly ask my clients for feedback on, you know, how is everything going? What more do you need from me so that you're feeling supported? So also be open to giving feedback if you feel like, you know, the relationship could work, but maybe you need a little bit of something different. You know, feel empowered to give that therapist feedback because we're here to listen and support you and give you what you need. So, you know, be empowered to take that step and find somebody that you're comfortable talking to.
Great. Well, thank you all. I can't say thank you enough. Thank you for, you know, your presence, your expertise, and thank you for your time. I know time is very precious. And thank you all, you know, who are joining us currently on both YouTube and Facebook. I am going to pass it off to Brenda so she can do the closing remarks. And, you know, hopefully we can take everything that we learned tonight and implement it into our daily lives moving forward.
Agreed. Amazing. Thank you, ladies. Dr. Diona said, be the one. That is so clutch to me because I remember when we first started this project in 2018, before we would head into a church, a school, a community center, I'd remind the team, we're going for one person.
Mm.
One person takes something away, we've succeeded. And that was in person, and now we're virtual, right? So whoever you are, wherever you are, just like Dr. Diona said, be the one person to speak to a family member, be the one person to open up if you're deciding or debating on going to therapy, be the one person to share this video with someone, be that one to subscribe on our YouTube channel and follow us on IG and Facebook. Be the one and share it, because you never know who will benefit from what is going on. So I'm my heart is full. The transparency and the authenticity that was shared tonight, it really is needed. And I do hope that through this conversation, change does come for our community, and that's what we're aiming for. To learn more about these amazing speakers, you guys, their bios are on our website. They will be there throughout this entire project that is concluding on September 23rd. So if you want to learn more about Josephine, the Mental Health Sisters, Tamara, go on our website. Their bios are there. Also, if you want to share this video and you're hesitant because you feel like your mother, your grandmother, your father will not understand, it's okay. We have something for them coming Wednesday. We're going to talk about depression in the Haitian Creole language. We're going to have speakers that speak Haitian Creole fluently. I will not be one of them on our panel, okay, to go right into it, just as we did here. So invite them. We'll be right here Wednesday night, 7 p.m. to 8:30 p.m., talking about depression in the Haitian Creole language. Again, head on over, follow us to YouTube so they can get that reminder that we are going live. Also, I did put this plug in during our Haitian Creole session last week on trauma, but not our English one. We give out scholarships every single year to Haitian American students. We started in the Boston area, the Massachusetts area, and slowly we'll start moving out to the other New England states as years to come. So please, if you know anyone who is currently in high school or even college, who's Haitian American that would benefit from an academic scholarship, a monetary scholarship, tell them to follow us online. Our scholarship program is growing, and it is only for Haitian American individuals, okay? We're taking care of our own, and we're doing what we wish we saw growing up. All right. So this is it. I think I got through everything I want to talk about. Again, thank you to our amazing speakers. And I am going to say it every day we end on time. It is 8:27 p.m. We are here, we are done, and we are educated better than we were when we first started this conversation on depression.
Definitely.
So thank you, Christina. Thank you, Josephine. Thank you, our mental health sisters, our doctors. Thank you, Tamara. And we look forward to seeing the rest of you guys on Wednesday night, or we look forward to seeing the rest of your family on Wednesday night. Have a good night, everyone.
Good night. Thank you so much.
Thank
Good
you.
night.
Good night.
Bye.